Good afternoon, ladies and gentlemen. My name is Nigel Howarth, and with my very good friend and colleague, Dr. Denis Tack from Belgium, we would like to welcome you this afternoon to this interactive teaching session, Common and Uncommon Errors in Plain Film and CT Imaging of the Chest, How to Improve Your Performance. We will show you missed lesions this afternoon that have really been missed. We will look at various anatomical areas, clinical entities and pathologies. We will include medico-legal cases, and our objectives are to interactively learn about the reasons for missing lesions and to help you reduce your risk of missing further lesions. We will concentrate on the chest X-ray, but we will show you several cases of missed lesions on CT scans. And I'll just remind you, of course, that the chest X-ray is very important for the management of patients with chest diseases and is still one of the most frequent causes of malpractice issues. So this afternoon, we will show you 33 cases with 29 questions. And we've tested these cases on clean fourth-year medical students who score an average of 50%. So you can compare your performance with those of these medical students. Now, just to make sure that everything's working, I turned 50 years old last month, and I have no embarrassment to try to give you a lesson for those of you who are in the room and are over 50 to how to use a smartphone. I've been to several interactive teaching sessions over the last couple of days here, and it doesn't always work. So if you have a smartphone, please use it. Please go onto the ECR Wi-Fi, accept the terms and conditions, and then when that's done, you can choose another Wi-Fi, which is the ECR 2014 Room A. And if you're blocked on Room C or Room F, then you have to change to the other room, Room A. Now, this is supposed to be automatic, but it isn't always automatic. So I hope some of you are connected. And I will ask you then the first question, and this is just for me and Denis and the technician to make sure that we're working together. So, have you come here to make a few phone calls in a quiet room, get some sleep in a dark and quiet room, talk to a colleague you have not seen since the last ECR, or to learn about errors in chest imaging? So if we could have the answers now, please. Well, thank you very much. Okay, the next slide, we don't need the technician to show up the answers. It's not very important. We'll gain a bit of time. Who are these two great men? Laurel and Hardy, Pat Garrett and Billy the Kid, Mick Jagger and Keith Richards, or the two Josés? Now, for those of you interested in chest radiology, you probably know the two Josés. José Villar, the man on the right with the sunglasses, is responsible for organizing all these interactive teaching sessions. He introduced them here at ECR. And any complaints about how this session runs, please send them to Professor José Villar. Okay, well, what you will see over the next hour and a half, every 3 or 4 cases, this yellow right angle will appear. And that's a clue for us to change speaker. So to keep you awake and alive, well, I will now hand over to Denis, and every 3 or 4 cases, we will change the speaker. So over to you, Denis, for the first case.
Thank you, Nigel. Good afternoon, everybody. It's a privilege to be here and to share the cases with you. So case number 1 is a 62-year-old woman with dyspnea, and she has a past history of ovarian carcinoma. Here are the frontal and lateral chest radiographs. And I will show you now the question. What would you report? A right pleural effusion, a left pleural effusion, bilateral, right larger than left, or bilateral, left larger than right. A few seconds again, the radiographs. Please vote now. Okay. Could we have the results? Bilateral, right larger than left is the majority of you, but you missed something. In fact, the left effusion is larger than the right. The right pleural effusion was reported as being larger. A puncture was performed in the emergency room and they got no fluid, so they requested a CT. And on the CT, you can see that the large effusion is on the left and not on the right. Looking at the radiographs again, in fact, you should look at the aortic arch and the air bubble in the stomach and detect that this is an error from the radiographer and the radiograph was inverted. This is the correct radiograph. What happened? A pneumothorax appeared on the right. The patient had to be intubated and stayed for 10 days in the intensive care unit. So, you may think that this kind of error never happens twice. In the same department 10 days later, a 63-year-old man presenting with dyspnea and a past history of laryngeal carcinoma. Here is the radiograph. And we reported a left pleural effusion. However, at bronchoscopy in the ICU, a tumor and a complete obstruction of the right main stem bronchus was observed. At CT, the effusion is on the right. Looking at the radiographs again, it's quite difficult to identify with certainty the right and the left side. Maybe the air in the left flank more likely correspond to the descending and not the ascending colon. Okay, so beware technical conditions. Now we have case 3 with an employee, an hospital employee, undergoing a chest radiograph for screening. This is the radiograph. Most of you have seen this.